Yeah. Yeah. There's two different.
No. But I did get the results for it. Other than that, wait. Wait.
Oh, she like when she walked in, she was like, she thought she was having a party over there. Yeah, she's so happy about that spot right now.
Where I feel like I'm pretty sure I'm going to.
Kelly, M-E-T?
No, I don't know why.
Oh, wait, are you sending it? No, I'm going to send your email. Okay.
I'm never going to. I'm never going to.
It's a Y, not an I.
Interesting.
Let me see if I can take it home.
I got a pack of matches. I
have to wipe out in the parking lot because I'm so graceful. Oh, beautiful.
Really, she just did.
Yeah, I printed out Thank you.
I like loving it over here. I'm looking outside.
I don't know what's here. I can grab your spot. Just like upstairs.
I'll just keep the same thing. Don't worry, you'll bring it.
Oh, yeah.
Can't get my little hard drive to work. Got downloaded from Blackboard. I think so. All right, test. Earth Worcester, can you hear us in our new digs up here in Manchester? I know you just had class, but I guess it's new to me. Hey, okay? All right, and feedback, all that stuff okay up here? All right. All right. A couple of things before we get started. One's starting to get a few more email questions about the cranial nerve assignment, and two things I just want to speak to. One, it's going to, whoops. It's on record. Is one, the exam and content. You will not be, the exam piece of it, the intent is we push you into the weeds of the cranial nerves, and then the exam part, you come back a little bit. And that's simply because of the diversity of people's interpretation of what to dig out on those. But the point is, cranial nerves will be on your final exam, and it will be in a fairly functional base or just in a location base, the way we've been doing things right along. In other words, you certainly should know the nuclei to cranial nerve 3 and 4 up in the midbrain and blah, 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 as far as that goes. So if there was damage or a lesion, what the functional result would be. And then also some basic discussions to assess function too as well that's included for each of those. As far as the assignment itself, people are starting to kind of, it's kind of fill in the blank, but kind of open-ended at the same point interpretation. There is no absolute as far as number of slides. Just kind of focus on, whatever the thing is asking for, put it down. You do not have to do a dissertation on each individual section. You're just going through the process to look at the big picture of 12 cranial nerves functionally. So any questions, concerns? So be it. All right. And then as we had talked to a little bit last time, it's not showing up on mine. Is that there all?
All of them.
Yeah.
Worcester, do you have a little end call meetings, whatever, pop-up box on your screen? Okay. Is this doable? Is this what it's been all morning? Okay. Can't handle the change, I'm getting my rut. Anyways, we do need to zip through these sensory tracts of the spinal cord. And to reiterate, again, speaking of final exam, there's only 3 tracts you have to be able to draw in the sense of if a lesion is here or here, what the net result would be. That's the lateral corticospinal tract. We've already done that. Descending motor. The other one is the dorsal column medial lemniscus, which I think we finished off last lecture on, which is conscious proprioception mechanoreceptors making their way up to the brainstem, thalamus, and eventually upstairs to your brain or cortex. The caveat, what I just wanted to kind of point out with this image again is here's that dorsal column medial lemniscus system. You should know the function, as we said, discriminating touch, vibration, and proprioception. So if there is a ding, if you know the pathway, which is it comes in, it lands, and goes up that posterior column on the same side. So if that ding, if you have a left spinal cord lesion involving that posterior column, you're going to have ipsilateral loss of those functions, that's all. And then the obvious, once it gets upstairs to the medulla, it crosses over, goes up that big ribbon thing of multiple sensory information, but the medial portion, known as the medial lemniscus, goes upstairs to thalamus and then eventually gets thrown upstairs to 312 and, the whole process we had chatted about. So that was dorsal column, but I'm pretty sure we had finished that one off. We had left off the list there. And so the next remaining is the spinocerebellar tracts, and I'm not so sure that we did get to these guys. Essentially, this is the subconscious information of what the posterior columns are doing. This is that real time. We looked at cerebellum, and it's doing this coordinated movement, trying to do things, information in real time, the feedback of what's going on. And it does it through these spinocerebellar tracts, and these guys are the ones that land in that paravermis vermis section of the cerebellum. When if you on another day and another time, and you had all this time to put it all together, you'd kind of take your cerebellar notes, your brainstem notes, and spinal cord notes, and connect the dots between that spinocerebellar tract into the cerebellum where it's landing, and eventually out the interposed nuclei, and off it goes to do its thing. But this spinocerebellar tract, one, know what the function is, subconscious proprioception, and then 2, there's 3 chunks of it, for lack of a better word, the way of push this out. There's an anterior and a posterior, and then there's really another posterior that's known as this cuneo-cerebellar tract. All 3 of them, subconscious proprioception. then. The only piece of it is just kind of recognizing the little nuances between each of those. The pathway you do not have to worry about in the sense of the way I talked about lateral corticospinal tract or dorsal column medial lemniscus. Just know it runs up the outside of the cord. Yes, it would be ipsilateral damage, but it's not as obvious. Other things are going on to kind of overshadow the loss, the ataxia that would occur. So I will not be chasing you on the, is this a contralateral loss or an ipsilateral loss? But, informationally, you should recognize it is ipsilateral. Whatever damage to the cerebellum or its associated tracts is usually ipsilateral. So back to the distinction. The anterior portion of this, so if you look on the outside of the cord on each side, this is what we're talking about. And on the front end of this thing, there's dedication towards information come from the lower extremity. And you read down here, it goes postural coordination movement, individual muscles of lower extremity. Then you skip down to the next one, and goes involved in coordinated movement, gross postural movement, entire lower extremity. In other words, if you think about it, the lower extremity, it's critical as far as proprioceptive feedback. You got to stand, you got to deal with, balance and equilibrium, keeping your trunk and your body, in this world without tipping over. So it's got more dedicated space. Not that your upper extremity doesn't need as much, because it does, but you're not walking around in a circus act on your hands, balancing. You're, doing coordinated movement, but not just as much dedicated track space, if you will, towards the upper extremity. So in the backside, this cuneo-cerebellar tract is the, strip that's dedicated to the upper extremity. So in simplistic terms, you've got the front, and then the next portion of this thing, a lot of this, 2/3 of this is dedicated to lower extremity, and then maybe a third is dedicated to upper extremity. Take-home message, though, functionally, they're all doing the same thing as far as subconscious proprioception. So this was a summary of what I had just chatted about, but I would just kind of bring your eyes up here to the lesion piece of this. It's rare. You're going to have a isolated ipsilateral loss of subconscious proprioception. Never seen it. Highly unusual. It's like you're never going to have a red nucleus only loss and cerebrospinal tract loss. It just doesn't happen that way. But if it is damage, there is ataxia that's going on in here, but there's other things going on with this individual too that it's pretty drastic and overshadowing. But the result would be ataxia. So same thing with that posterior column and the outside. Damage to either of those, you're talking ataxic type impairments. Friedreich's ataxia, there's spinocerebellar ataxias and 52 subsets of those. They call them SCAs. There are clinical conditions involving these, but the net result is some form of ataxia, but you can't isolate it as cleanly as you do a Brodmann's area or as, the lateral corticospinal tract, that cleanly, that's all. All right, so that's spinocerebellar. Sneaking over to the last chunk of information to go upstairs. Pain and temperature. And that's what goes up through this group of ascending known as anterior lateral spinal tracts, if you will. And essentially, you have the lateral spinothalamic tract, and then you have a group of others that are going up and landing in the brainstem and landing in a few other areas. In general, they're all taking care of this pain, light touch, temperature kind of sensation to get up there, but there's little nuances between each of them. So the first one, lateral spinothalamic tract, this is the third one you have to know. So basically, you need to understand with a spinal cord injury what would happen to voluntary movement, what would happen to balance and proprioception of those posterior columns, and here finally on the third thing, what happens to pain and temperature. And based on the location of the lesion, you should be able to predict if it's ipsilateral, contralateral loss, that's all. So how does this lateral spinothalamic tract work? is implied. It's going up the spine, going to the thalamus. And function-wise, it's taking pain and temperature and localized pain at that. In other words, eventually, it's going to throw it up to that 312 to say very specifically, ouch, it's my thumb that hurts. So it's giving some location or meaning to where those nociceptive or pain fibers are coming from. So how it does it does a little different pattern than the others. Essentially, it comes in, gets in the dorsal horn in the back portion of that spinal cord, and lands. Truth of the matter is, it has a lot of interconnections. Remember we talked about those rexid layers, and sometimes they talk above and below. With pain and nociception, there's a lot of crosstalk, kind of microcircuitry at the spinal cord level. Our purpose is push that aside, it lands in the dorsal horn, period. Now the next step, it's got to go upstairs, but what it does is cut across immediately at the spinal cord level, and then it gets over to the lateral side and goes up that direction. That's where the name lateral spinal thalamic tract comes from. So again, comes in, first order lands, second order picks it up, comes up the lateral side, so lateral, eventually lands in the thalamus, and then the last connection is thalamus upstairs to cortex 312, telling you it's your thumb. So that's the lateral spinal thalamic tract. That's the third of the quote-unquote big three basic tracks you need to be able to just simply map out on this whole pathway between cortex, thalamus, capsule, and brainstem, and spinal cord. So that's very specific, localized, ouch, it hurts, pain, identification of pain. The other ones, so this is the lateral spinal thalamic tract is a little bit more on the outside here, quote-unquote lateral part. But then you have a group of other tracts that are going up, conveying the same information. And these are a little more towards the front, so they're referred to as the anterior spinal thalamic tract, or some of these other terms you'll see in a second. That's where it comes from. But in simplistic terms, this is the very localized, specific, that's my pain and temperature. This stuff up here, it's going to convey pain, it's going to convey light touch and temperature and these things, but it's more in a diffuse way. It's going to land in the brainstem, it's going to land in the thalamus and go to those sub-levels, those limbic levels, that cingulate gyrus, insular gyrus, all that stuff, and not put a spot on it, but just give you an emotional check on the nociception or pain, that you're feeling. So that's really the role of these three or these ascending tracks. But functionally, they're often grouped together as quote-unquote anterior lateral spinal system. So they make their way up. So so that's the first one. The anterior spinal thalamic tract is kind of this first little subset of pathways in that front end group. Theoretically, it says light touch. That's a little simplistic too, but kind of just take it for what it's worth at this point as far as information goes. Spinal reticular tract, we talked before about pain comes in, it's going upstairs, telling your cortex, it's my thumb. It's also going to my, eventually my limbic system and some of those lobes to jolt my memory of what thumb pain means to me, and give some kind of visceral reaction. But it's also landing in the spinal cord to say, hey, you got pain down there. Let's do a little reflex modulation. Let's control this thing. And so those information, that input, is landing in the reticular system that we had chatted about, and then sending a loop back downstairs to modulate it. So that's known as the spinal reticular tract. So again, comes in, ascends, and goes right up to the reticular. It doesn't really keep going. It's just dumping off fibers and landing in those reticular nuclei that we had talked about. So critical role as far as modulating, but when you look at all this, goes arousal, perception of pain, that's the more emotional piece. But the arousal piece, limbic system, what did we talk about? Alert, oriented, and keeping you up there. What do you do when you're trying to assess, clinically, or you give somebody a pinch to see if they react to pinch or pain, and you're trying to get the reflex loop in this deep core reticular system to see if that person's functioning that way. So that's kind of the connection with it all. And as I said, in healthy scenarios, you're also getting some descending information, modifying the pain. Then you have information coming up. This is more upper extremity, if you will, or upper half of the cord, but spinal tectal, tectum, superior colliculi, inferior colliculi. We've talked about those, so that's where it's coming from. You need the feedback to get upstairs, and some of these visual reflexes and reaction to pain and nociception and other types of sensory input. That's where this is coming from too, as well. So essentially, lateral spinal thalamic tract, this group a little more on the outside, real specific pain information. And then you move a little more anterior, and this stuff is a little more diffuse. It's more core, it's more visceral, it's more reflexive information with what is being conveyed. So that's in a whole, though, known as that anterior lateral spinal system, if you will. So that's where the terminology comes from. All right. So those are the basics. Understand what's going down, understand what's going up, and know where they're landing. And again, an individual with a tumor, an individual with a spinal cord injury, or any other kind of pathology, you should be able to put two and two together as to where their functional loss is coming from and why, and how to have a basis for assessing that too as well. All right, did want to briefly talk about spinal cord injury and autonomic dysreflexia associated with spinal cord injury. Very, very basic, simple, but conceptually, this part of the CNS is no different than everything else we keep chatting about. If you have a ding, you're worried about the obvious primary area that got damaged. So somebody, has a car accident and they've had the vertebrae, burst and smash into the cord and physically, damage a chunk of that cord. And obviously there's necrosis damage to those cells that were hit by the bone. But then that whole secondary immune response, inflammation response is critical. And that's the area often that emergency and timely intervention can help minimize and help save some function for that individual. So that's really the gist of this page, is to again bring that concept up. We talked about that upstairs in the cortex on a stroke, same scenario here. So huge doses of corticosteroids, dexamethasone, and again these are kind of old notes. There may be some different versions of what's used now, but the concept's the same. Huge dumping in of anti-inflammatory to try to contain that mass spread of inflammation that's going on. A couple other things going on spinal cord wise. Spinal cord injury, you never know. It's just like CNS damage. One person's stroke is not another person's stroke. One person's going to have a functional recovery here, another one to here, another one way up here, and you don't necessarily know as to why. Same thing with spinal cord injury. First question, am I going to walk again, is usually the one, if it's severe enough to involve that. Nobody ever knows. Don't ever answer that question if you're on the front ends of that. You're going to do everything you can to optimize the chances to walk again, but you can never answer, hey, am I going to walk again? But back to the discussion. There's a couple generic phases that do go through. So despite the little nuances of details of injury, the CNS will go into just a mass dose of a shock or shutdown, for lack of a better word. In other words, when you have a CNS injury, there's certain patterns that show up, in your motor function, et cetera, as far as reflexes and muscle tone. Usually if there's a CNS injury, the muscles are going to be spastic or excessive tone. Your reflexes are going to be hyper reflexes, and that's usually because the CNS can't come down and kind of put a governor switch on those lower reflex loops. So there's too much going on. If someone has an injury where you just snip the peripheral nerve, you just pull the plug on the extension cord, the muscle goes flat line, flaccid. So you have, hypotonia or no tone, and then you go in and try to hit a reflex and get the cycle to go. There's nothing there. It's been snipped. So it's hyporeflexia. So when you memorize this upper motor neuron, lower motor neuron patterns, that's kind of what it's referring to. But during the acute phase, all that kind of goes out the window. In other words, everything just gets shut down. Roughly 1, 2, 3 weeks, again, depending on severity and situation. But the clinical piece of that is everything shut down. So motor-wise, a true flaccid, nothing, no toned, everything, no contraction going on. Reflexes, zippo. So areflexia, hyporeflexia, not there. So not what you'd expect. Once, further down the line, it's the exact opposite. So in the acute phase, this is probably the biggest, difference, I guess I would say. Everything else down here should, kind of fall into place or make sense to some degree as far as, what you've done to the cord. I'll sneak down here. Blood pressure, again, major issue as far as autonomic pathways getting back and forth, and we'll talk about that with autonomic dysreflexia. But early on, again, everything is shut down, so you're on talking very low or hypotension. But eventually the body's starting to recover from whatever the trauma was, the damage was, and things are starting to wake up and fall into place. And in this phase, and again, depending on the recovery, it may just be what it is for them, that motor tone turns into hyperspastic, too much tone, and the CNS has lost its ability to take all this information and kind of, monitor those low-level reflex loops. And so same thing with the deep tendon reflexes, hyperreflexia, clonus. Clonus is just simply, again, if you've seen it, you know what I'm talking about, but it's, say you have an Achilles tendon reflex, you go in, individual with the spinal cord, and you just tap the reflex no harder than you would the next individual in the next exam room, and their foot goes, but it also back and forth, back and forth, back and forth, back and forth, and it finally slows down. That's clonus. But again, if you see it, you know it. But again, it's part of this whole hyper state that we're talking about, motor control, if you will. Again, feedback to maintain autonomic feedback's disrupted. Individuals going from supine to upright, gravity, a lot of inability to monitor and compensate and have reflexive control over blood pressure. So orthostatic hypotension is an issue for some individuals. But the other term, autonomic dysreflexia, that's the one, whoops, I don't quite get there. I'll talk about that, I think, in a slide here. Spinal cord injury, again, it can fit, it's its whole entity and time and discussion, and, a specialized area of medicine and care. But to kind of put some of the stats out there, and I'm not even touching the tip of the iceberg, but statistically, we're thinking, okay, well, you have to be in a wheelchair, you have to have this impairment, or you've got to be on a vent of some sort for assisted breathing. And we think of it mechanically at that impairment, but the reality is their physiology is drastically altered, and because you take for granted what your physiology does when it moves around and everything else, when they can't do that, individuals with an SCI, they're really kind of speeding up or putting their physiology more at risk of not being able to cope with life or aging changes that go on or disuse changes. So classically, these individuals have a shorter life expectancy. You think of the individuals, media, people out there. I've had patients that I've worked with, and sadly, spinal cord injury is associated with younger age individuals, higher risk behavior, things like that. So often it's a 20-year-old, a 24-year-old, but I've been involved in the care to have them pass away at age 40 or 42 or 38. So it's definitely more than meets the eye than the isolated functional loss, I guess. But again, it's a whole doesn't even do justice the whole amount of attention it would deserve to discuss spinal cord injury clinically. Autonomic dysreflexia, though, I did want to bring this up because it's an emergency scenario. It may occur just simply, you may be involved in primary care, an individual with an SCI coming in for something unrelated and triggers into this event, on your table. And you should be aware of what it is and just simply what to do in the 2 seconds that you see it going on. But essentially, because of the injury, you've lost that autonomic control that we talked about. And so again, things autonomically, classically, it might be bladder feedback, it might be sensory feedback, but they're things that will, under normal circumstances, wouldn't be an irritant or a stimulus for something to go on. But essentially what happens, for example, if the bladder is too distended, it becomes that sensory input that's autonomically going upstairs to tell you that's going on, that's conveyed as an irritant and an agitation that's triggering this huge, massive sympathetic discharge. I mean, huge, massive sympathetic discharge. And so when that occurs, sympathetics, you know what that does. And so you go into this huge, huge hypertensive state, 200, 250, 300 kind of big numbers. And so you have this going on as your, immediate emergency scenario, if you will. And so essentially you would think, okay, can't everything up here get that feedback of blood pressures up here, baroreceptors are telling me, can't we have brainstem come down and calm it down? Well, the injury doesn't allow that, controlling stuff to put a kibosh on this hypertension. So what you have is this feedback coming irritant, throwing this huge sympathetic discharge without the feedback to calm down that sympathetic discharge, and they remain in this hypertensive state. The irony, though, is, I don't know if that's the right word, but heart rate-wise, you get the exact opposite. You still do have parasympathetic vagus response to the heart. So what you wind up with is you do have the modifying control of heart rate comes down. You have a bradycardia, but you have this massive, massive hypertensive state. So the real caveat, and oops, I should have popped this up here. So here's the stimulus, the irritant. It's going to blast out the sympathetic discharge. Feedback comes upstairs. The information to get down to slow that sympathetic discharge isn't there. But again, the vagus pathway is there and can allow the heart rate to come down into a bradycardia, slower rate type scenario. So the caveat with all that is, A, know what it is, but B, more importantly, if it's going on in front of you, what to do. Instinctively, we always think those shock positions and, get legs elevated and that, and it's the exact opposite. And that's why I bring this up, is you literally put them into gravity position, a gravity-dependent position. If you lay them down, it exasperates the whole scenario going on. That's not going to solve the problem, but that's the safest position if you can be safe with them. Obviously, if they can't, they have to be in something that's safe to hold them in the upright position. But the real solution is to immediately get rid of whatever, the stimulus is. So if it's a bladder issue and if they have a catheter, you're making sure you've, avoided that bladder or done whatever you've done. If it's clothing, you've removed the clothing. Whatever the case is, it might be impacted bowels and they need to have, bowel treatment to be able to have that occur. So the bottom line is get them up, remove the stimulus. And that's really what you're doing besides the 911, depending on wherever you're at. So that's autonomic dysreflexia. So know what it is, but also know what it is to react to. As I said, even though you may never be in a spinal cord setting, rehab setting like that, I've had plenty of patients do it on my exam table that I've been working with. So you just need to be able to identify it and react to it. All right, last but not least, as we said, dings. We talked about dings in the cortex. We talked about dings in the brainstem, cerebellum in a generic way. And then spinal cord, essentially, I'm going to give you three scenarios, and this is what I'm referring to. In other words, if you know those three tracks and the functions of those tracks, if you cut the cord right in half, you should be able to predict what's going to go on. That one's fairly easy because you're going to lose everything below it. Doesn't matter which side it's coming from, it's not getting up there. Doesn't matter which side it's coming down, it's not going to get to do what it's going to do. So a complete transaction, the whole cord involved, you've lost everything, proprioception, vibration, discriminating touch, pain and temp, and motor output on both sides of the fence. So that one's easy. Other scenarios, anterior cord syndrome. Remember we chatted briefly about the blood supply or different scenarios that can occur and how it's divided up into the posterior supply does the back columns and anterior spinal does the front column. But other things can occur, but damage essentially the anterior 2/3 of the cord. So your job in that scenario is to kind of put the two together of what may happen here. But again, it's pretty easy. Just if it's both sides, it's pretty easy to say, okay, I've got motor loss. If it's far enough out in the lateral corticospinal pathways, I've got all that pain and temperature loss. And it's going on both sides, everything below it. Who is spared? Proprioception, discriminating touch, going back up the posterior columns. So again, that one's fairly simple too as well. The other scenario is if you cut this one in half, I damage the cord this way, and now you look at who's involved. So what am I going to lose? I'm going to lose essentially some proprioceptive stuff. I'm going to lose some pain and temp, and I'm going to lose motor. But the real question is which side? So proprioceptive comes in, lands, and goes up that posterior column. Hasn't crossed over, so essentially everything on the same side below the injury. Corticospinal is coming down on this side. It's already crossed and going out to whatever it's going to go out to. So same thing. It's a lateral motor loss or hemiplegia. And then last but not least, what does pain do? It lands in, crosses over immediately, and then it wants to go upstairs. So this is the one that will wind up being a contralateral loss of pain and temperature on the opposite side. So that's what I mean by the big three. I hear I'm yakking about it forever. You might get a token question or two questions relating to this, but you have to be able to kind of follow the schematic to make it work out. And then there's a final classic, scenario, the central cord syndrome. Whether it's a tumor-based type scenario or a cyst-based, a CSF type thing, different causes will result in essentially wiping out the middle or the central piece of this cord. And the big player in all this is really those crossing pain and temperature tracks. Remember we said they come in, they land, and they cut over, and then they go upstairs. So in this scenario, often you get a bilateral pain and temperature loss, and classically, in textbook academic world, they use a keep-like distribution in terms of that. Some of that's based on that somatotopic location that we had talked about, and we really didn't chase too hard, but that's where that's coming from, I guess, is where I'll leave it at that. But the bottom line is, often it's something that can or may be addressed, medically, surgically to resolve the pressure, the damage. And so I guess the scenario is it tends to be typically a little bit more treatable than, a massive transaction to a traumatic spinal cord injury. So those are the four, if I think I can count right this morning, scenarios as far as the tracks. So I'm going to leave the discussion at this point. So from this point forth, I used to kind of get into some discussion, a little more functionally about it. We don't have time. Every year I get to this point and say we're not going to go over this, so it's not like you've lost anything different than your predecessors going through the program. So I can't read. So is this slide 148? No. The thing is so dim. Can anybody read that slide number? Who knows? But this is central cord syndrome. Draw the line, do whatever you need to do in your notes to say, that's it for neuro, black hole, it's here for final exam. All right, can we put neuro to rest? All in favor, say aye. Aye. Okay. Yeah, that's an enthusiastic aye. All right. All right. I'm going to take 5 minutes to at least kind of feel like we've been doing renal this first half, just so I can mentally feel better that we're going to get Module 1 renal done today. I think we will, but you know me. I think we will. We never do, but we will try. Renal's a little bit more straightforward about what we need to do, especially Module 1. And it's my understanding, have you done renal twin medwise? Okay, all right. You've done it pharmaceutically? Is that accurate? Have you done anything renal? That must have been on Planet 9. I thought I'm always trying to overhear what your next exam is. I could have sworn you had renal. So I thought I was reinventing the wheel a little bit here, but at least we're in sequence. All right, the renal, again, just like we've done right along the same mantra, is really just to look at what normal physiology is, look at it a basis, the way I've approached this. Eventually, Clin Med, you'll come in with the different pathologies, discussions about, acute and chronic renal failure and, the causes to get there, these glomerulopathies that attack the filter part of it, other things that attack the nephron. But I'd like to look at the physiology, maybe in a, again, a pretty simplistic way, but try to put a spot where some of your different diuretics, again, it's America, hypertension and pharmaceutical cocktail for hypertension is, by the millions. And being able to have an understanding where those different diuretics and things are acting, just trying to get that basis before you guys hit the ground with the real speed of the Clin Med piece of everything and the pharmaceutical piece. So start out the gates with probably a review of our anatomy. The standard thing is I always sit here and say, yeah, it's 4 inches, it's teeny. I am always shocked when I hold the kidney in the cadaver lab. Same thing I told you in anatomy. But I'd like to look at it today. We'll briefly look at the gross piece of things, but a little bit more as far as the functional and the pathways of what it's doing. Kidney-wise, too, if you think about it as, blah, 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 as far as filtration and getting things out of your body. But the other piece of it that we'll look at is its role just simply in fluid balance and blood pressure balance, too, as well. And its major role as far as acid-base balances, too. That's Module 3. All right, so gross anatomy, what do we need to chat about? Not too much. The CT, the saran wrap that's truly wrapped around there is the renal capsule. We talked about fat being around it, and adrenal being engrossed in that fatty area. By definition, the renal fascia is the more gross covering of it. But you peel it down to that kidney, and that true outer layer of connective tissue is the renal capsule. Then moving down functionally, you've got the outer area is the cortex, and then these patterns of pyramid triangles. This region in here all represents the medulla. Now we'll dip into location. We're going to be talking about the nephrons, obviously. The glomeruli represent the ball of that filtration unit, and then obviously the proximal and distal tubules are the pieces going down and forming the loops. So they go down and come up north and eventually hook into a collecting duct. Up in the cortex, though, the glomeruli, they sit all around these guys. In the medulla, essentially, you only have a small percentage of those loops going down in there. But really the key is this is where all the concentration is going on, the ability to concentrate or dilute your urine functionally. So that's probably the biggest difference between the two areas. So other terminology, renal papilla is just that very tip of these subsections, these pyramids that are going to land and eventually hook up with the calyces, or this draining mechanism. You have a minor calyce, a major, a renal pelvis, and a ureter, which again, I think we did in anatomy, and I think I have them showing up on a slide or two. So that's the renal papilla, but as I said, it's the apex of each of those functional subsets of these pyramid-shaped things. So this, again, as usual on the slide behind whatever I'm babbling about here, but you should recognize the functional piece of this is these nephrons are filtering, doing their job at a micro level. Eventually, they're dumping them into these collecting ducts, but eventually it lands down here. And once it gets out here, it's done and gone. There's no more concentration or any absorption going on. This is nothing more than collecting a funnel system to eventually get it down in the ureter, that's all. So it's the hierarchy is the minor calyce, the major calyce, and then eventually into the common ground, which is this renal pelvis. And then once you hit the ureter, again, a couple slides later here, it's smooth muscle. So, you're going from a funnel collecting duct into a smooth muscle system to propel it down to the bladder. So here's our smooth muscle. End of story. I don't think there's anything else I need to say with that. And we'll continue the story. Okay. Moving on to the nephrons. Looking at each, I don't know how, I've got 1.2 million. That's a whole lot, obviously. So these are teeny, but, a million functional units to be doing their job. But depending on that location, they have a little bit different function, if you will. There's some that remain out in the cortical outer portion, not in that medulla, not in that pyramid that go down in deep. And so those guys, their loop barely sneaks into this pyramid or medulla region. And they're really not involved in concentrating or diluting the urine necessarily. They're just more involved in what the kidney also does, reabsorb or filter out whatever you need to keep back or push out of your body, if you will. There's kind of a mid-cortical, but then you sneak down, and these juxtamedullary ones, which are the glomeruli are, technically in the cortex or cortical region, but essentially that loop is dropping way down and forming that, functional unit at these pyramids, and this is where all the concentration essentially is going on. So there's kind of a gross discussion of dilution, concentration of the two. Then you sneak down, and we're going to look at the nephron, I think, if I can know how these slides go. But we're going to look at the nephron from the front end, which is filtration, to the back end, which is dumping it into a collecting duct and eventually getting into the minor calyces. So the renal corpuscle, this round ball at the start of all this, and if you think about this, essentially, as you know, that's where the filtration's going on. So what is it filtering? Basically, the blood system, your blood vessels, and then you want to get it into this mechanical open space known as a nephron and eventually a collecting duct and down into the bladder. So this is the junction of the two. So the glomeruli, that term is referring to that bundle of blood vessels, that capillary bed of blood vessels. Bowman's capsule is referring to the very end of that nephron, kind of the opening, end to get in this container or this tube system known as a nephron that eventually gets into a collecting duct that eventually gets into the calyces and down to the bladder. Then within this thing, there's some specialized cells laying around. These guys are known as mesangial cells. They're smooth muscle and have a phagocytic role. But one of their roles, we'll get to it in a slide or two, but since it's here, we're discussing it, is that smooth muscle can contract or relax. And so again, we've got a site of filtration, and obviously filtration is based on surface area. So if you have more surface area, you can filter more. If you contract and take away surface area, you decrease your filtration. So these mesangial cells give a little bit of control of, the rate of filtering. They can kind of increase or decrease it based on whether they're contracting. So the glomerulus itself, it's, as I said, it's a capillary bed, and at the blood supply lands in, you have an afferent or an arriving arteriole that feeds into it. It gets in this Bowman's capsule and then pushes out or filters out whatever it's going to do, and then it pushes it off to a second capillary bed that's going to go around all the rest of the nephron, essentially. But within this thing, these capillaries, there's a pattern. This is a filter. It's not just a static, mesh net that, your brain mechanically thinks about filtering. It's got 3 layers of meshness, if you will, and also uses charges to help repel. But the capillary itself has its own mesh, that fenestrated wall. So lots of holes in it to allow, only certain size particles to get through. There's filter number 1. Second filter behind it is this basement membrane, negative charge. So even if something's small enough to sneak through the fenestration, if it's got a negative charge, you've got repelling action. So there's filter number 2. And then last but not least is essentially, really, it's the epithelium of Bowman's capsule. If you think about it, here's the tube. It all wants to get in this space where that tube is. You've got the outer piece of that. It's landing here, but it can't just be an open-ended thing. It has a visceral piece to it, if you will, and it's a specialized form made up of these podocytes, and those two create a whole mechanical slit mechanism, if you will. So you have 3 layers. You got the capillary wall physically, size-wise, not let stuff through. You've got a membrane charge to repel, and then you got one more level of mechanics, which is really the inner wall of Bowman's capsule that's not going to let stuff through too as well. So all the glomerular pathologies that go on, these there's different subsets and types. Some attack the basement membrane, some do different portions of that, and I think that's what you'll be, running through with the speed of light in Clin Med when the renal specialist comes in to talk about. But that's one site where obviously you can lose kidney function and disrupt the function of this filtering mechanism. So that's the glomerulus. We've got plenty of, as usual, 228 pictures, so I got plenty of pictures to kind of support it as you start wrapping your head around. This one isn't too bad. This represents the capillary. That's the wall itself. It has its slits. Here's that basement membrane. And then it's kind of the artist's rendition of how those podocytes sit in there. I think I have much prettier ones. I do. I think this is fascinating. This is, right in there. That's the glomerular capillary. And these are the podocytes of that inner part of this Bowman's capsule. But they push out these projections, these foot-like projections that have space between them, enough for things to get through, but enough to block. So it's a pretty amazing setup when you look at the pretty microscopic pictures. They almost remind me of the astrocytes. Remember we talked about astrocytes making the blood-brain barrier? Same kind of analogy if you think about it. So, all right. I feel good we started, so let's now take our 5-minute break or whatever, and we'll finish this thing off.